Welcome back to Season 2 of the Pager podcast. So in this episode, we look at a topic that I've been wanting to discuss for a while now. That topic is uncertainty, and my guest today is Dr Arabella Simpkin. Dr Simpkin is a paediatrician by training and assistant professor of medicine at Harvard Medical School. She's an advocate for really embracing uncertainty within medicine, not only to improve patient care, but also to improve the well-being of clinicians, and she's written, researched and spoken extensively on this topic. As will become quite obvious, this is such a vast field, and although there are lots of things that we only touched upon briefly, I hope it can fuel a lot of further thinking about this topic, and I know I'll certainly go away and do a bit of thinking as well. We start off by talking about the sources of uncertainty within medicine, whether relating to a particular diagnosis or surrounding what the effects of a particular treatment may be for an individual patient. This gets us on to exploring the origins of doctors' relationships with uncertainty and how lack of comfort can lead to poor patient care and also contribute towards burnout amongst clinicians. We also touch upon important questions over how best to communicate uncertainty to patients and how much should be communicated at all and when. There was also discussion of methods for improving clinicians' comfort with uncertainty and indeed their acknowledgement of its existence in the first place, whether through changes in language used or peer support, for example. As ever, if you have any thoughts or questions, we'd love to hear them, and you can email us at pagerpodcast@gmail.com or tweet us at pager_podcast. Dr. Simpkin, thanks so much for coming on the podcast. It's really great to be talking with you today.
Oh, it's a pleasure to be here, and great that geographical distance doesn't prevent us from having a wonderful conversation.
I don't think I could afford the flights over to Australia currently. Or the 2-week quarantine in a hotel.
Right, exactly.
So I wanted to kick off, in fact, just by asking you what got you interested in the first place in studying uncertainty, particularly in the medical sphere?
It's a great question, George, and I sort of often think back to how it happened. A lot, I think, happening at a subconscious level as I went through medical training myself. So, I think like many of us, we go into medicine often with a clear desire for the sort of increasing our knowledge and being in an incredible profession. But definitely, I think many people who go into medicine are quite used to sort of knowing the right answer, doing well in tests, doing well in exams, and we then go to medical school, which often sort of connotes a false sense of right and wrong answers. And I think partly that's the way we test people, and a lot of our assessments being multiple choice questions. And a lot of this is now changing. But certainly when I was at medical school in the early 2000s, I think I sort of kept assuming that by the time I became a doctor, I would sort of know the answers. And a lot of the people I looked at seemed to really be very confident and secure in their knowledge and in their the way they spoke. And when I became a doctor myself, and I sort of often tell this story that I still vividly remember, I started on night shifts, and my first night shift, I sort of turned up, I suddenly had the word doctor adorned in front of my name, and I sort of felt that I should know all the answers, and that if I didn't, it was a symbol that I didn't really belong. And I remember the registrar going off to bed and, quite confidently saying that he would see me in the morning unless there was a life-threatening emergency. And I wandered around the wards, and about 2 a.m, my pager went off, and it was a nurse on the other end of the phone asking if I would come and prescribe something for a patient who had some painful hemorrhoids. And I remember sort of confidently saying, of course, and putting down the phone, and then totally panicking and thinking, I could have written an essay on the pathophysiology of hemorrhoids and the epidemiology, but what to prescribe at 2 a.m. for a patient with painful hemorrhoids, I just didn't really know. I looked in the Oxford Handbook of Clinical Medicine, and didn't really give any bright ideas. And whilst I'm sure the nurse knew exactly what she wanted me to prescribe, I didn't feel able to say I don't know. And in a way, knowing that it wasn't a life-threatening emergency made me feel actually even more unconfident to ask anybody for help. So fortunately for me, my father is a physician, and I remember literally going into a broom cupboard to phone him to ask him what I should prescribe. And it's only looking back at that I sort of can see that in that moment I was tapping into somebody who I knew would respect me and sort of not question me for saying I don't know. And as I went through then my sort of pediatric training, I realized how many of us really struggle in this space of uncertainty, and how many struggle to actually admit that we don't know. And looking back, I realized that that maybe was a sort of had been inculcated by the sort of training that we do. And as I looked at how we select for medicine, I became increasingly fascinated by this idea that maybe we actually were selecting for people who really don't tolerate uncertainty in the way that we look at the space, and became interested in really beginning to research whether our tolerance to uncertainty does affect burnout and depression, again, which are sort of huge spaces that have grown in importance over the last couple of decades.
I'd love to get onto that a little bit later on. I'm curious from what you've said, how you think about this, the different causes of uncertainty, one of which is glaring in my face as a medical student, being actually I just don't have the information at my fingertips. I don't understand what's going on here, and I'm pretty sure that most other people do who are senior to me. And actually this real uncertainty that exists almost between everybody in managing something, and how we avoid conflating the two with each other.
It's a great point, George. And I think one of the things that I, really promote is that I think senior role models really need to explicitly discuss uncertainty and how uncertain they often feel. But I think at a junior level, it's very hard to know what are the known unknowns and what are the unknown unknowns. And so to be sort of confident in speaking about your uncertainty, I think is easier as you get more senior and you have more security that just because you don't know doesn't mean you don't belong. I think when I think about the different types of uncertainty, one of the, I think trying to work out where are the unnecessary uncertainties. So where can we minimize our sort of stress from uncertainty by looking at where are those uncertainties that do just lie from incomplete knowledge. So, one of the sort of most common ways probably that uncertainty is sort of dichotomized is thinking about it in two dimensions, one of which is, as you say, this sort of idea of the epistemic uncertainty, which comes from the Greek root sort of epistem, meaning knowledge. And I think that's that piece that does relate to our incomplete knowledge. And that arises both from limitations in existing scientific knowledge about a medical question, but also limitations in our ability to access and process that knowledge. And I think that is trying to work out how we manage that piece and how we encourage certainly junior people to feel confident to really think about those, and then minimize where it is that actually just finding out more knowledge will minimize some of the uncertainty in any scenario.
And I've certainly noticed this, that you only have to have slightly more information than somebody else to seem like you're much more in control of what's going on.
Right.
Occasionally people have told me and they've said, oh, you seem like you knew what you were doing. And I was thinking that's ludicrous. And then I look at
totally.
In the same way, and I look up to my supervisors and other doctors around, and I think you really know what you're doing. And then occasionally there comes a moment where actually somebody higher up the food chain comes along and says, no, you don't.
Right.
It's very interesting.
Well, and actually to go back to that example I sort of spoke about at the beginning, it was only years later that I even felt confident to tell that story, that I'd sort of phoned my dad, in the middle of the night. And actually I can see my sort of fellow house officers were there saying, gosh, you really seem to look like you knew what you were doing. And actually, so often we're very good at putting on this masquerade of complete sort of self-confidence that often, I think it links into imposter syndrome and all sorts of other sort of spaces. But I think for many of us, we feel like we're the only one who doesn't know.
And to what extent do you think that this is a product of almost two groups of facts or pieces of information that we should know? There are the things that we're expected to know and the things that we feel that we're not expected to know, we're not embarrassed to ask about or refer on, for example. How do you think about that?
I think, this sort of builds onto the space of psychological safety, which is a sort of space that was originally recognized outside of the medical space. Amy Edmondson, who's a professor at Harvard Business School, is one of the pioneers in this space. But that looks at how do we try and encourage people to be able to be vulnerable and share their uncertainties, share their insecurities, share when they don't know. It's been shown to be a very powerful predictor of good, high functioning teams and teams that are able to function in spaces of uncertainty. But I think I think for many of us, we do worry about saying, I don't know, to something that maybe everybody else knows. And, it's very hard to know how you truly create a culture where people don't feel that they're going to be judged. But and I think a lot of medical schools in particular are looking at whether moving from models of actual grades to just pass fail can help with that, whether by sort of reducing this sort of idea that you're still striving to get high scores, and whether we should be just looking at, you know, whether people are competent or not, and whether by sort of reducing that sort of sense of people feeling like they're constantly competing and so having to keep all their cards close to their chest, whether that helps. I think it also can help to have mentors and people you can talk to outside of immediate sort of channels that you're in, because I think often there is a sense that being truly vulnerable with people that you potentially feel you're competing against can be very hard.
And I think it's also true that given there's no syllabus as such to medicine, there are going to be things probably that you don't know that most other people do know, and filling in those gaps isn't necessarily something to be ashamed of. It's a part of, I think, learning and the different experiences that people have had along the way.
For sure. And, you know, different specialties, you know, some fields, you know, allow people to become real experts in very small spaces, and other fields, you know, sort of general practice, you really have to be a jack of all trades and, you know, sort of know a little bit about everything. And so I think it also depends on the space in the field that one goes into. And of course, that medical knowledge is constantly changing. So we're sort of constantly, things that even may be certain and true today, you know, may down the line end up not being so true.
You can sometimes find bits of medical information that are actually being taught quite widely that are, when you talk to other people, seem to be vastly out of date.
Right. Well, and even one example I often use, of course, is the Wakefield study in the Lancet, linking the MMR vaccine with autism, that at the time, you know, published in the Lancet, a high impact, highly regarded peer-reviewed journal that you would think would sort of make something, you know, in inverted commas, certain knowledge. And yet obviously that paper ended up being retracted and has had huge damage to sort of rates of measles and mumps and rubella with the lack of that vaccine uptake. But sort of, you know, that's just one example of something that even when published and sort of theoretically certain in an instant, you know, can go on to have such ramifications.
Perhaps one thing behind that is the difference between impact and certainty, and perhaps those two things can be conflated, particularly in the publishing sphere, that actually, well, high impact factor journals are associated with certainty about something, perhaps where actually the methods and the authors and even the journal itself would freely admit that's not the case.
Right, absolutely. And I think it's one of the challenges actually, even in sort of the era we live in now with the internet and sort of plethora amounts of information, you know, that often the written word can seem true, can seem to have sort of certainty to it. I think one of the other pieces of this that I often touch on is the use of language that we use around sort of certain things. So even within the medicine space, when we, you know, think about some of molecular genomics or precision medicine or some of the artificial intelligence, some terms can sort of connote a lot of certainty, whereas you say, you know, it isn't the case. And, you know, I often think that the other example is, you know, something that can give you a statistic at a population level to the individual patient can still be rife with huge uncertainty. Even though when you look at something sort of at a higher up level, often as we're looking at things in journals, sort of it can seem more clear cut than it is to that individual patient.
I think it's interesting, and I've heard you speak before about one particular case of terminology and perhaps the difference between talking about a diagnosis and talking about a hypothesis. I think this moves us on to talking about a slightly different sort of uncertainty with this diagnostic uncertainty, as opposed to, which kind of links in, but as opposed to, I think what we were talking earlier about uncertainty, what do I do now? And I was wondering how you think language plays a role here.
Yeah, I mean, I think this was a very interesting study that we did with the Harvard Medical School students, looking at, you know, at that sort of handover of a patient from the emergency department to the inpatient ward, and just changing the use of the word around what the sort of presumed diagnosis was. And so at times we use the word diagnosis. So the handover would say, you know, the diagnosis is pneumonia, or we use a working diagnosis term, or we use this term hypothesis. And very interestingly, the students that were randomized to receive the word hypothesis had significantly increased stress from uncertainty, which the only thing that had changed was the use of that word hypothesis as opposed to diagnosis. And it really got us thinking about, the connotations with those words. And some of this builds on Kahneman and Tversky's work around framing and around the way we process information, but was a very interesting concept that actually, if you talk about a hypothesis, which often we really are dealing often in hypotheses in medicine, but when we talk about diagnosis, that seems to connote a much sort of stronger sense of certainty. And we were interested to think about whether using words like hypothesis really would connote to other providers that we're still very much in the sort of understanding diagnostic phase. Because one of the big dangers that happens with diagnostic error, which obviously has huge preventable morbidity and mortality associated with it, is that people can anchor and have all sorts of biases that people sort of hone into something and put other things into their blind spot. And whether using words like hypothesis helps to remind everybody that it's still uncertain.
One nice term I've heard here is diagnostic inertia.
Yes.
Which came across today, in fact, kind of pushing you down this direction of thinking something. And I think I always find it interesting, actually, that looking where a particular diagnosis has come from, and often it's perhaps not even come from the person who you think it's come from, the person who it's written in the notes. Actually, they've copied it from somewhere else, who's copied it from somewhere else, and it can sometimes be lost exactly where this decision has even come from in the first place.
Oh, absolutely. That sort of Chinese whispers where something does get lost. Yeah.
I'd like to touch upon something you were talking about a few minutes ago, about how this lack of comfort with uncertainty can have some quite negative impacts, both on patient care and perhaps a bit later on actually burnout and mental health of clinicians. Can I start with the patient care aspect of it? In what ways is this lack of comfort, do you think, detrimental?
Well, I think, primarily our sort of lack of comfort in our own reaction to uncertainty often can prevent us from disclosing the true uncertainty. And so we ourselves as providers can make something seem more certain than it is because we don't really want to acknowledge the uncertainty ourselves. And we know this to be true, that many physicians do struggle to disclose uncertainty. Now, clearly in the sort of era, of shared decision making and where sort of that true good provider-patient communication is is a cornerstone of good medical practice. I think learning to be able to authentically discuss uncertainty is critical if we're going to have true shared decision making. I think one of the other dangers is that we often as providers think that if we do more tests, we will get more certainty because we'll have more answers. And ironically, often the opposite is true. So we not only do we have false positives and false negatives, so we can sort of end up with that with a sort of addition of uncertainty, but obviously also there are often risks to tests, either iatrogenic injury through invasive tests, but also just the anxiety and psychological stress that additional tests can cause to patients. So I think that's also something we really have to think about in how it impacts patients. And then, of course, coming back to what we were just talking about, the sort of diagnostic error part, that one of the biggest dangers of being intolerant of uncertainty is that we go into premature decision making. So we close down our decision making too soon. And we know when we look back at medical errors that have happened, sort of misdiagnosis caused by sort of premature closure is a very common cause of diagnostic error. And I think a lot of that is linked to our reaction to uncertainty.
To what extent do you think that this enthusiasm for getting to a diagnosis, certainly from a clinician's point of view, is partially, I was just thinking of this now, related to how medicine has been taught in terms of segregated into conditions? Once you've actually put a label on it, it's suddenly a lot clearer for how you should proceed forwards. The textbooks tell you how to treat an appendicitis, for example, but they don't tell you necessarily as easily how to treat something that has a 70% chance of being that and a 30% chance of being something else.
Right, absolutely. George, I think you've really hit on one of the, big challenges of a sort of move towards kind of guideline protocol driven medicine is that we're constantly wanting to be able to get onto the protocol and have the answer. And I think, as we sort of alluded to at the beginning, I think one of the challenges of how we teach medicine, and we certainly are trying to change this, and it's a space that is expanding at a rapid rate, but it's how we make sure we don't sort of prioritize getting the right answer or getting an answer at the cost of not being able to sit comfortably in the unknown. And I think as we said, one of many sort of type A personalities go into medicine who like to know the right answer, and we spend a lot of time inculcating through multiple choice questions whether you're right or wrong. And I think reframing how we think about how we teach this whole space, so that we try to avoid this sort of desire to have an answer at the cost of the uncertainty. Now, I will caveat that by saying that obviously at some point you have to be able to make a decision despite uncertainty, and you have to come up, you sort of do have to move forward. So and I think it's where this space is sort of complex, that it's not just a linear space. It's a challenge to get that right sweet spot.
Going back slightly, there are obviously a couple of things at play. There's the fact that actually, what is the cost of reducing your uncertainty, and is that bearable for the benefits of it? And also the fact that you alluded to, which is that that you directly touched upon, that actually sometimes you're not really doing what you think you're doing when you're reducing uncertainty, but you're creating a hole. You might be throwing open a can of worms in that respect.
And I think, trying to work out how much uncertainty the patient themselves wants to tolerate. So all of us as individuals can tolerate different levels of uncertainty, and it probably changes contextually depending on the sort of stakes that are at hand. But I think that working that out with the patient as well, to understand how much uncertainty they themselves can tolerate. We think about this often with sort of watchful waiting. Some patients are happier to sit and wait, and others find that sort of anxiety of the uncertainty too much.
I would definitely like to touch upon that a bit later. I wanted to also ask, to what extent actually this increasing kind of medical legal environment is also potentially playing a role here, in that people are worried about under-investigating things. They're worried about perhaps not finding something that they should have found, even if actually 9 times out of 10 it would have been disadvantageous to investigate so much to reduce this uncertainty slightly, and whether there's a slight barrier to it here.
Oh, I'm sure that is true. I think the sort of huge medico-legal space does make people worried about not having sort of crossed all the T's and dotted all the I's, and I think that plays into also thinking that more investigations and sort of having black and white concrete information at hand can help in that space. I think it's a difficult space. There's obviously also a sort of ever increasing number of different treatments and investigations that get thrown into the mix as well, that adds to it. But there's no doubt that I think that space of the medico-legal piece undoubtedly plays into how providers make decisions.
And I wonder if actually a better understanding and communication of uncertainty could be a way in which actually to properly justify a position without over-investigation, and a way forward out of this.
Yes, and I often also think that, especially sort of in the United States, where healthcare is much more clearly sort of billed by sort of billable moments and investigations, there's sort of no billing code for a discussion about uncertainty. And in many ways, and we sort of talk about this in some of the work that we've done, we need to also address how we think about uncertainty at the system level to sort of promote a space where really talking about uncertainty is prioritized and valued, because at the moment in our system, it isn't really valued.
And it certainly has a huge impact on patients themselves and their experiences, and actually our ability to make meaningful decisions and the optimum decision for a patient in front of us.
Right, and changing the expectation. I think centuries ago, patients would come to the doctor for the answer, for the sort of diagnosis, to know what was wrong with them. And whilst that clearly is still true today, I think there's sort of more nuance where often patients have looked up a lot of the sort of knowledge, the black and white knowledge themselves. And whilst clearly the doctor has significant amounts of training in how to understand and process that knowledge, I often think we sort of need to change the expectation around that saying that the not being sure is a value. And some papers have shown that saying I don't know does actually increase trust in the patient-provider relationship, which is something we know has positive knock-on effects to healthcare outcomes. But I think changing some of that expectation of what's expected and that sort of being certain is not necessarily the end goal.
And I find that really interesting because my gut feeling would perhaps point in the other direction. It would say that it could reduce confidence by almost the very thing that we talked about a bit earlier, that by saying that you don't know, I'm sure that somebody else knows, and actually it could just be you as a doctor.
Oh, absolutely. No, I think many of us do worry. We sort of historically have sort of hidden and suppressed and ignored uncertainty because we feel it suggests fallibility. But it is interesting to realize that actually, if you say I don't know, but follow it up by saying, but you're here with the patient for the journey, you're going to help sort of do your best and stick with them, that actually has increased trust.
And that by saying I don't know, that's not the same thing as saying we're not going to do anything, I've got nothing to add to this.
Right, and that's a very important distinction.
And going back a little bit, I'm curious also how advancing medicine is also changing slightly how patients and doctors see uncertainty, in that perhaps diagnostic errors and things like that were less commonly recognised a long time ago, when actually perhaps follow-up was there. We didn't have as good a diagnostics perhaps later down the line, and how actually things have shifted towards actually creating perhaps, I think you've written about this, from a patient's perspective, actually a lack of trust when something that was deemed to be certain actually turns out to be completely wrong. And that uncertainty hasn't been shared, and actually it's been proven that actually that certainty was falsely placed.
I mean, exactly. And I think one of the other challenges with the sort of shift in technology and that changing space is that actually the machines have now taken over a lot of the black and white sort of the black and white algorithmic information, whereas as humans we sort of therefore are left in the grayscale space, in the sort of space of uncertainty. And I think I often say I think the world we live in often sort of has us all now used to, at the touch of a finger, being able to sort of get what we want. And I worry sometimes that translates across for patients into the medical space of feeling like that same, that increased knowledge leads to sort of us being more sure, when actually, because uncertainty borders the edge of knowledge, increase in knowledge also exponentially increases the uncertainty.
And I think if technology had the answer to all of our problems, I'd make a lot more correct decisions and have the answers to everything. But actually, I found it's very much not the case as a medical student, that actually your phone contains the answers to all things out there. Another question I had relating to actually communication of uncertainty is how can we effectively, study the ways in which we approach uncertainty actually affect a patient, and what are the best ways to do it? What are some of the things that we should avoid doing? Because it seems like the research here doesn't necessarily have the same endpoints as we'd see traditionally in clinical trials for drugs or surgery, for example.
Right, George. Well, you've touched on, one of the hardest pieces of medical education research, which is how do you actually look at that sort of end outcome of effect and impact to patient care. I think there are a lot of challenges, but it is certainly where we strive to be able to look. In the space of uncertainty, I think one of the first challenges in how you research it is how you actually sort of understand how uncertain somebody is. So we are limited really to surveys. There's no kind of magic blood test to show how uncertain somebody is. So all of the sort of metrics are kind of deep, have a lot of subjectivity inherent in them already. And then, of course, it's hard to really be able to sort of single out what was the impact of uncertainty to a decision and then to the sort of patient outcomes, because clearly there are all sorts of confounding factors that go in. So unlike the sort of pure basic science or clinical trials where you can try and sort of control variables in a much more rigorous way, the space of medical education research really sits within the messy, real clinical world. And that makes all of this quite hard. Now, that's not to say that it's insurmountable. And I think, certainly beginning to look at how people's tolerance of uncertainty changes potentially with curricular efforts. So increasingly, the GMC and educational bodies around the world are recognizing the importance of being able to sit comfortably with uncertainty for medical students, for healthcare providers, and it is now seen as a core professional competency or milestone. And I think that in itself is going to lead to us having more opportunity to try and see whether curricular efforts and interventions to help people tolerate uncertainty better will shift people's sort of sense of uncertainty, and then be able to downstream look and see, what impact does that have on diagnostic error? Does that help reduce premature closure, which itself could help diagnostic error? And that undoubtedly is a sort of would be an incredible place for this research to be able to go. And I think there's a huge a huge avenue of different questions we could then ask.
And has there been any research into how aware doctors actually are of the uncertainty around the decisions that they're making? I wonder.
Yes, I mean, this sort of touches, there's also been a lot of research done looking at, how confident people feel in their decisions. And some of this has been done in simulation settings. So that probably is as close as we can get to trying to control things. So bringing doctors into a simulation setting, and they've done scenarios where they, ask providers how confident were they in their diagnosis. A lot of this varies as well by personality type. So some people are just inherently more confident and sure about their decisions. And it obviously also is contextual and changes, I think, with the sort of type of scenario. But it definitely is an interesting space to try and think about how doctors feel about uncertainty and when are they aware of it? Because one of the biggest challenges is that so much of this happens at a subconscious level.
And I wanted to also touch upon some of the research that you've been doing surrounding tolerance to uncertainty and burnout as well. And I was wondering if you could talk about that for a little bit.
Yeah, so this is sort of was when I originally started thinking about this space and looking at colleagues. I was a paediatric registrar in London and was looking at several of my colleagues, many of whom it did seem were sort of burning out. And yet these were people who had, often gone to the best medical schools, come top of their year, done well in all the exams. It definitely wasn't a case that they were struggling because for sort of any obvious reason other than sort of really struggling with the environment. And as I started looking at it, I began to realize that many of these people were people who really liked knowing the right answer, and that it seemed to me that the uncertainty of so much of the medical space may be what was driving it, especially as I then started thinking about it and realizing that we never really had any training in how to cope with uncertainty. So when you look at a lot of other fields, there's often a lot more thought that goes into how you cope with uncertainty. One of the spaces that I've particularly been fascinated by are the Navy SEALs, who do a lot of thinking about, how do you make difficult decisions in the face of uncertainty when there's high stake outcomes and high responsibility. The aviation industry is another industry that thinks about this. And clearly as doctors, we are having to make difficult decisions in the face of uncertainty all the time. So I began to just do some initial research into looking at how does reaction to uncertainty affect depression and burnout. And probably sort of unsurprisingly, what I had hypothesized did seem to be coming to fruition, that the more stressed you are by uncertainty, the more likely you are to be burnt out, the more likely you are to be depressed. Now, clearly that sort of led me to really step back and think, wow, here we are really in a space where there's uncertainty all the time. So if you're stressed by uncertainty and you're more likely to be burnt out, we really need to be looking at how we can help people manage that uncertainty. One of the good things about this space is that we know that tolerance of uncertainty is a modifiable trait. So you can learn to become more tolerant of uncertainty, but it's definitely a space that I think has huge impact to burnout, which, in many ways is at an all-time high globally.
And is there such thing as certainty in uncertainty?
Absolutely, definitely. And in many ways, I actually think that's probably the sweet spot that one's aiming for, because we're never going to get rid of uncertainty altogether. So you have to learn to be able to sit comfortably in uncertainty, not close down too soon, sort of narrow your blind spots, but also be able to make a decision in uncertainty. So one of the things we see in people who are very intolerant of uncertainty is that they can really become paralyzed and go into decision avoidance because they just find that uncertainty paralyzes them. And so it's sort of wanting people to be aware of uncertainty, to think about it, to help it drive their curiosity and make better decisions, but be able to make a decision in the face of it.
And I sometimes think that there are decisions almost, if a decision doesn't lead to the outcome that you want it to lead to, that doesn't necessarily mean that it's the wrong decision, because it can be actually something that you would do again and again, and you are playing a numbers game to some extent, and you can expect to lose that game, and you want to mitigate against the consequences of that, but it doesn't necessarily mean that you should strive for 100% accuracy. Where actually that's impossible.
Absolutely. And I think, that's one of the things where senior role models need to be, explicit about where they were wrong, and times that, we are certainly never all going to get it right all the time. And clearly one wants to put in, safety nets to try and mitigate as much as possible wrong decisions, but being able to think about it and then learn from it. I think trying to put in place good feedback loops so that we really do learn from our sort of diagnostic pathways and help it inform our decisions in the future is so important.
And this may be a slightly strange analogy, but I wonder if it works here. But I sometimes think of it in sport, actually, and I think of occasionally people can be congratulated for something that they've done which comes off in the end. And I turn around and I think, actually, that was a terrible decision to make. That's come off a chance because of essentially luck in this situation, and it's not necessarily something you want to repeat again.
Right.
That's the other end of the spectrum.
Right. No, absolutely.
And I wonder what sorts of things do you think in medical education could be brought in actually to help this tolerance to uncertainty and therefore better management of patient care?
Better management of patient care, and also sort of helping the individual's well-being as well. So it's twofold, sort of twofold impact. I think undoubtedly, being explicit about where uncertainty is. So I think, I sort of think when we think about taking a history from a patient and presenting complaint and history of presenting complaint, I sort of think there should be a space in that for discussing uncertainty, how uncertain is the patient, what's concerning them, so that we really explicitly are bringing this discussion into our sort of everyday vernacular. I think explicitly talking about where could possible uncertainties be, where could our blind spots be, where could our biases be, sort of leading us to not open up and really look about whether there are other uncertainties in this space. There's a sort of nice phrase, prospective hindsight, where you sort of look and ahead of time imagine that your working diagnosis is wrong, and go back and sort of look at the signs and symptoms again and see if you can sort of open up that differential diagnosis list and sort of rethink, because we know when we go back and look at medical errors with hindsight, it often becomes clear where things weren't sort of looked at. So trying to look at that ahead of time, I think, is a nice way to think about where we could be missing some uncertainties. And just making sure that, within medical school curricula and sort of specialty training programs, we really are thinking about the impact of uncertainty and decision-making science and some of the sort of psychological elements that come into play. And I always just encourage people to really step back and actually think for themselves how they handle uncertainty, because I think so often we don't actually sit back and even think about what our own reaction to uncertainty is.
Another question I had was actually how you mentioned slightly patient's tolerance to uncertainty, but how you go about deciding how much to share in this respect of the uncertainty around lots of different decisions, which is even more complex when you add add together the pressures that patients face in hospital and related to mental state, physical illness, etc.
Oh yeah, George. I mean, this is sort of the magic bullet of how do you know how much to share? Because there's no doubt that we know that there are, psychological and physiological benefits to a concept of certainty. I mean, I know that there are sort of studies that show that, something like 67% of the time, if you just take a white chalk tablet, but you think you're taking an aspirin, your headache will disappear. So there's huge, power in belief. And I do sometimes worry that we need to be very careful in this field that we do still, that we don't go down too big a rabbit hole of always talking about where everything's so uncertain and nothing being sure, because I think that in itself would lead to a huge amount of anxiety that would not be helpful. So I think trying to understand how much to share is really one of the spaces this field desperately needs some answers in, and how we quickly work out how much uncertainty is going to be sort of helpful for an individual situation. And I think so much of this is nuanced depending on both the patient's reaction to uncertainty, the physician's reaction to uncertainty, the context of the case. And like anything, it sort of comes back to that idea that really what we crave as humans is having a protocol or a guideline for everything. We'd love to have in this scenario, this is how you deal with it. This is how much uncertainty you talk about. And unfortunately, I just don't think that's how the field will develop.
And I imagine, much like doctors who like certainty, actually patients may like certainty, and almost their satisfaction might be quite high when it's put across, but they might be quite detrimentally affected by it. And teasing apart what this effect is and the line to, I think, walk between the two extremes of complete certainty and explaining all the uncertainty that there is there, I think is quite difficult, really.
Right. I mean, the placebo effect is huge. And often, the placebo effect is often there because people really believe in what they've done. They have certainty around that, even though actually that isn't the case. And I think that is where this is such a difficult field. And, you can look back to Hippocrates in the 5th century, BCE, who sort of, in a sense, sort of alludes to uncertainty in medicine. So I think this is something that goes back for thousands of years, and probably we recognize now how complex a space it is and why there's no easy fix.
So perhaps to finish off, if you could put your finger on some of the research that you think you would like to see happen, if you had unlimited resources within this, what questions do you think we should be targeting, and how do you think we should construct this research in what is evidently such an important field?
I think there are certainly different areas for future research that I'd love to see develop. So undoubtedly sort of in the neuroscience space, how do people process and interpret and respond to various types of uncertainty? I think we definitely need research in the communication space. So how do we, we've talked about this through this podcast, but how do we work out how to best communicate uncertainty? What are the mechanisms of framing the way we speak, the language we use? How do we assess individual preference? And then, of course, we spoke about how do we really look and see what is the impact on patient quality and safety and sort of healthcare outcomes? So can we do some research to sort of understand what impact it may have, sharing uncertainty, sort of discussing this more? Can we think about what that would do? And then probably just to finish off and, sort of show how much research is needed in the space, I think really working out how we accurately measure and quantify uncertainty is critical for us to really rigorously be able to look at this field. So there is no doubt that there is a lifetime's worth of research questions to explore, which is exciting.
Which brings us into a whole another topic around probabilities and applying the evidence to a patient in front of you, which I think would be too much for today. So I think I will probably leave it at there, because I know you have other things to get on to. But it's been an absolute pleasure to chat with you. So thank you so much.
Oh, my pleasure. I mean, you could talk about this so much. That is what I find amazing. There really is just so much, and you sort of start thinking about it and you just realize the snowball of things that unleashes.
Thanks for listening to the Pager podcast. If you've enjoyed it, do leave us a review, share it with a friend, and come back to listen to our other episodes. As ever, we'd love to hear what you think. You can reach us at Pager Podcast on Instagram and Twitter, or email us at pagerpodcast@gmail.com. Bye for now.